So you guys probably know this stuff already, but this is 2018 numbers, about 1.7 million newly diagnosed cancer cases in 2018, 600,000 deaths. So a lot of people get diagnosed with cancer. 5-year survival rate for all cancers increased from 49% in 1976 to 69% in 2010. And I believe it has continued to improve. So cancer patients are living longer, and there's a lot of them, and increasing survival rates means more patients in need of physical therapy. And I think overall there's been a big shift in cancer care to focus more on actual quality of life rather than just survival. So that's where a lot of physical therapy fits in, is improving quality of life and stuff like that. I'm not sure what everybody's background knowledge regarding physical therapy is. So this is a profession that's been around for a while. It started in response to polio and has been progressing through the decades. So it initially was just it was an undergrad degree. It then progressed to a master's degree. In 1996, it started shifting to a doctor of physical therapy degree, and now it's completely phased out the master's degree. So doctor of physical therapy degree is your entry-level degree. It's 3 years of postgraduate education. Recently, there's been more of a specialization focus in physical therapy. The oncology specialist certification began testing in 2019. So it's very recent, but it's great. The oncology physical therapy group is kind of booming right now. So there's a lot of new stuff coming out. In general, that you guys may know this, but I'm talk about it a little bit. Physical therapists, we really can't prescribe anything. We can't prescribe medication. We can't order imaging. This may change and is changing. So like if you're a physical therapist in the military, you can order imaging. Different states are able to order imaging. I'm not sure. I don't think they can order any medications. But basically, like, after you graduate and start practicing, you'll have to acquaint yourself with your state's laws regarding physical therapy. Overall, throughout the country, physical therapy is shifting to what we call direct access. So years ago, to see a physical therapist in Illinois and most other states throughout the country, you need a referral from a doctor or a PA or an NP. This has changed, and it's changing state by state. So currently, Illinois has restricted direct access. So a physical therapist can see a patient without a physician referral, but they need to notify the physician within 5 business days and get them to sign off on their plan of care. If there's no functional improvement within 10 to 15 days, they need to refer back to a physician. And if a patient returns to the physical therapist within 30 days of discharge for the same diagnosis, they need a physician referral before they can return to PT. So that's just for Illinois. It's going to differ state by state, and it really isn't this way for every site. So currently at UCM, I'm not completely sure why this is. We do not accept direct access patients, something in how we've written our rules internally. So at UCM, we do require a physician referral to start physical therapy. So physical therapists are part of basically every healthcare setting: acute care, inpatient rehab, outpatient, home physical therapy. And then these are, how I was saying, the oncology physical therapy specialization started in 2019. These are the other areas you can specialize in as a physical therapist. So clinical electrophysiology, geriatrics, neurology, oncology, orthopedics, pediatrics, sports, women's health, and wound management. We have most of these specialists here at UCM. I don't think we have a clinical electrophysiology specialist. I don't know anybody that has that one. And then we work, as part of the broader rehab team, occupational therapists, speech language pathologists, recreational therapists, dietitians, and there's PT assistants, OT assistants, and then rehab aides and techs. So we all kind of work together on the rehab team. So this is a slide about kind of when a physical therapist should get involved with a patient's treatment. So really, not for everybody, but typically it can start right at the diagnosis. So as soon as someone gets a diagnosis, they are potentially able to see a physical therapist. We usually call this Pre-hab, and we'll go into that a little later. We frequently see people during and after their oncology treatment for various different reasons. And then we can see them at end of life care, like palliative assistance. See them during and after their disease progression or relapse. We can see them after their treatment for just surveillance. And then if they have chronic issues, we can see them chronically. So really throughout the entire cancer survivor continuum, we are able to be involved. So go back, this prehab. So prehab is kind of a newer concept for us, especially in oncology. So after diagnosis, but before initiating their cancer treatment, we can see these patients, and we can do a workup, assess how they're functioning, what any issues are, create a treatment plan for them. So identifying either their baseline functional measures prior to treatment to see if there's any, if they're at risk for anything significant, or identifying things we need to work on prior to them even starting their treatment, initiating exercise programs, things like that, to decrease the potential side effects from their treatment. Okay. So prehab, so oncology physical therapy is somewhat of a newer area of research. So we're trying a lot of new stuff, seeing what works. Right now, the research that shows good benefits from prehab, specifically patients with lung cancer, colorectal, or GI, gynecological cancers are three that have had good research outcomes. So things we can improve with prehab are cardiopulmonary function. Prehab in some of these research studies have shown to reduce hospital length of stay, reduce post-surgical costs, reduce rate of infection, improve your tolerance to chemotherapy, so more patients are able to complete their prescribed chemotherapy dosage, reduce rate of readmission, improve return to continence for some specific cancers, and improve overall function. I'm going to stop there, see if anybody has any questions. And if not, I will continue going. All right, I will continue. So this concept of prehab and that whole continuum of cancer care with physical therapy it's kind of led to this newer kind of buzzword concept that we use in oncology physical therapy. It's called prospective surveillance model. So this is just a treatment model for physical therapy, which right now is kind of what we're saying is the ideal gold standard for oncology physical therapy. Basically, we're seeing patients in that pre-treatment time. And this research is mostly for the prospective surveillance model is mostly referring to breast cancer patients, but it can be applicable to different types of cancer. So basically screening patients initially before they may even start treatment, kind of defining what we think their risk is based on these pre-treatment assessments, deciding what sort of frequency we need to be reassessing them at, and then deciding, what kind of intensity they need for their physical therapy treatment based on that pre-treatment screening and then these follow-up assessments. So we can triage these patients into different treatment intensity groups, give them patient-specific exercises, decide how much monitoring they need, and educate them on what sort of side effects they may encounter, when they should come back in for physical therapy, when they should contact their physician, things like that. So we at UCM, we see patients throughout the continuum and across all cancers. Basically, we have inpatient, adult, and pediatric oncology, physical therapy, outpatient, adult, and pediatric referrals. Some of the more specialty clinics we work with at UCM, where we do more of this entire continuum prehab type stuff. The Childhood Blood Disorders Clinic, we work with patients in the HIPEC clinic. I don't know if you're familiar with that. That's somewhat a new thing. We work with pre-op and post-op lymphedema surgery clinic. So then we're doing those preoperative measurements, pre-treatment measurements. Pre-op axillary lymph node dissection clinic with Dr. Juskowiak. And then we work with, it used to be just the geriatric stem cell and CAR T optimization clinic, and now it's broadening to all stem cell and CAR T patients. We're going to do baseline measurements with them and then track them throughout their treatment and afterwards. So kind of this prospective surveillance model of physical therapy. And I'm going to turn it over to Maria.
All right, hello, Maria Alvarado, just coming in to talk specifically about complications that can occur after treatment for cancer. As you can see, it's a pretty long list of impairments that people can have both during and after treatment for cancer. I think with physicians, there's a lot of focus on what positive changes are going to come from chemotherapy, from radiation, from surgery, curing cancer and saving people's lives, frankly. So there's a lot of focus on the treatment and doing all the treatment that is necessary. I think as the physical therapist, it is important to make sure that patients are aware of the side effects that can happen. Because it oftentimes blindsides them. They're expecting maybe after this treatment that they're going to go back to 100% normal functioning, when in fact, some of these changes that happen to their body can be permanent. And so bracing them for the possibility of long-term consequences of cancer treatment and survivorship. So just breaking it down into some of the really common complications from chemotherapy, probably the most common side effect is neuropathy. Neuropathy can cause weakness, impaired sensation, impaired balance. That can be in the short term as people are receiving treatment. But for some people, neuropathy is a long-term consequence where their sensation can be impaired permanently, causing pain or causing balance issues. Usually it resolves within that first 6 months after treatment, but possibly not. That would be a reason for someone to come to physical therapy if that persists. With radiation, obviously skin changes take place with radiation. You can get wounds from the treatment and then the long-term and short-term consequences of impaired skin flexibility. That's something that we could address with physical therapy. Surgery, the big thing is scar tissue, removal of certain tissues causing permanent changes to the anatomy. And as a consequence of some of the incisions and the size of some tumors, certainly there can be nerve and muscle damage, which can lead to weakness and loss of range of motion. We see a lot of patients in that category. Get a fair amount of referrals for scar tissue. Unfortunately, scar tissue is one of those things that we don't have a lot of influence on, but tried to work around the impairments that come from that. And then the more long-term issues are going to be fatigue, deconditioning, can can have bone loss as a result of hormonal changes, and or pelvic floor and sexual dysfunction is a common with gynecological surgeries. The next complication that can happen after cancer treatment is lymphedema. We're going to dive a little bit deeper into the topic of lymphedema because Tom and I both happen to be, if you saw it in our first slide in our titles, certified lymphedema therapists, CLTs. So this is an area that we have specialization in and feel like that it's often an under discussed topic amongst cancer patients, but in the general population as well. So we like to do our job to educate as many people possible about lymphedema. So if by the end of this, anyone has questions, specific questions about lymphedema, we'd be happy to answer more about that. But in general, lymphedema is caused as a result of cancer treatment, that cancer metastases commonly travel throughout the lymphatic system. The lymph nodes are removed and or damaged during assessment and or treatment for different types of cancer. They can be damaged by radiation and they can be removed for helping to diagnose and stage people's cancer. The lymphatic system in general is part of the immune system. It's responsible for removal of high protein, large molecules, and as a result, fluid removal, waste removal throughout the entire body. When the lymph nodes are damaged or removed, patients are susceptible to lymphatic fluid accumulation, resulting in swelling or lymphedema. And the presence of that fluid and the protein makes them at risk for infection. In general, lymphedema diagnosis typically begins with the patient's self-assessment. They perceive a feeling of fullness or heaviness in the limb, or it can begin as a visible swelling or a pitting swelling. We're going to get into the stages of lymphedema, but oftentimes it's not necessarily obvious to the observer. And lymphedema can occur in any body part. It's most commonly referred to in the arms, because a lot of research about lymphedema has been done in the breast cancer population. And certainly the sentinel node lymph node biopsy came out of mostly patients with breast cancer developing lymphedema and physicians wanting to prevent that from happening. But it can certainly happen with any type of surgery or any type of radiation, or if there's enough tumor to be blocking the lymphatic system in a particular area. We measure lymphedema in various ways. In the next slide, I'm going to have some photos of the different ways of measuring. We use tape measures to take circumferential measurements of the limb, which results in a volume calculation. We also use water displacement in the lower left-hand corner to get a very accurate representation of hands and feet. It's kind of the best way to measure volume. The other two machines on the right, one is a pyrometer and the other is a bioimpedance measure. These are more advanced ways of using science rather than, new technology versus old technology for assessing. We use these devices both preoperatively to have a baseline limb volume and limb girth or fluid content, so that if a patient is starting to report changes in the limb, we have something to compare to prior to surgery. The threshold for lymphedema diagnosis is really just kind of for research purposes, but we take those volumetric measurements in general. And if there's a change in limb volume not accounted for by weight or weight loss or weight gain, maybe 10% or more would be considered significant. So I said I was going to mention a little bit more about the staging of lymphedema. So here are some examples on the left side of arms and legs of stage 1 lymphedema, where there is some swelling present, but it might be reversible with elevation or with dietary changes just on a daily basis. It can fluctuate quite a bit. And stage 2 is where you have edema on a daily basis. It doesn't go away at night. It doesn't go away with elevation. And the limb is obviously different to the contralateral side. Stage 3 is where you start to get some skin changes happening. Thickening of the skin, no longer pitting really, can start to get some papillomas, other hyperkeratosis occurring. And then stage 4 is your severe case of elephantiasis, really a deformation of the limb. and loss of some function because of the severity and the weight of the limb and restrictions in motion. On the right-hand side, we've put in some sort of extreme cases of lymphedema. The top one is a possibility of severe scrotal lymphedema occurring in a patient probably with a gynecological cancer. And on the bottom there is an example of lymphedema of the face and tongue area. As you can see, that tongue is quite swollen, but so are the cheeks and eyes even in that particular patient.
Sorry to interrupt. I just want
Please.
to clarify. So is that scrotal lymphedema?
Yes, it is.
Okay. Probably not a gyne cancer then, right? Probably pelvic.
Oh, I'm sorry.
No,
Yes,
okay.
thank you. Excuse me. A pelvic cancer would have been the better term there.
I haven't seen that. Wow.
Yeah, it's a pretty extreme case. You do see cases like that. That's, at the level of elephantiasis, certainly. That happens more commonly associated with filariasis is a primary cause of lymphedema in tropical regions.
Yeah.
You do see scrotum like that in those cases. It's relatively, thankfully, rare here in the US.
I've seen that with CHF, but that's easier to reverse.
Yeah, it's just sort of an overflow of fluid rather than a dysfunction of the lymphatic system.
Yeah.
Absolutely. And I think it's important. It's possibly something that gets passed over a little bit too much, I think, in regular medical school. I think oncologists have a good understanding of lymphedema because there's oftentimes an association with lymphedema and oncology. But there is a whole population of patients that we also treat with lymphedema, not related to cancer, just genetic lymphedema. And it's a diagnosis of exclusion. So it gets forgotten about quite often, but it's a very common occurrence, both primary lymphedemas and secondary lymphedemas from cancer treatment. So we like to make sure.
I have a question. I'm curious as a physical therapist, do you feel like patients often come and feel like they were informed that this potentially was a risk of treatment, or do you see a lot of people who are kind of shocked or surprised when they have symptoms or, develop something like lymphedema?
I think there's so much information coming at patients at the time of diagnosis and treatment that it maybe gets mentioned, but they don't register it on their radar, right? Because they're so focused on the treatment that they're focused on the treatment and the cure, that all of these side effects don't really get talked about. I think in the breast cancer population, because it's such a common phenomenon and there's good awareness about it, that those patients are educated on it more than any other type of cancer patient. I think it's the more obscure patient. Recently had an example of a patient with melanoma of the chest wall with an axillary dissection. There was no education, no even possibility or thought in their mind that they would come out of surgery with a swollen limb for the rest of their life, but they did, right? So I think warning and education with any of these surgeries that are pretty drastic, a full axillary dissection, a lot of lymph nodes removed, radiation to the area, it's a high possibility for these patients that they're going to have some complications down the line. So I would certainly encourage education on possible effects.
Yeah, just a quick anecdote was when I first started in practice, I treated a fair amount of head and neck, and I had a patient about a year after I started who called panicking because he had swelling under his chin that had suddenly developed 6 or 8 months after treatment. And it was just submental lymphedema that actually eventually resolved. But ever since then, it's really stuck with me that when I see those patients, I make a point just to warn them, you might get swelling under your chin for several months afterwards. And I've had them tell me like, oh yeah, I'm glad you told me that because it happened and I didn't panic. But
they didn't freak out about it,
right.
Or that they would know to report it to you as soon as possible so that they could come in for treatment of it as well.
Yeah, and we do refer for that very commonly for head and neck cancer. So
it is quite common. I think, people know about arm lymphedema, but genital and face lymphedema, is not as talked about, certainly.
So I have a question. Is there any possible way I'm sure they're very complicated, but to drain some of the swelling, or I don't know, it just seems kind of, I mean, for me, it just looks insane for one thing.
Yeah.
Just how it can swell up like that.
Yeah.
And the second is, there's just that one point.
Yeah, absolutely. And I would say that's probably the most common question that patients come in with when they're first developing these symptoms. They're like, why can't I just get this drained, right? And it's because it's interstitial fluid. It's not a seroma. It's not just an accumulation of fluid in a particular area that you could just poke a needle into and drain out. It's in between every single cell of the dermis. It's present above the muscle, above the fat, right in the dermal layers, and in between every single cell. So you cannot drain it. The fluid has to be absorbed into the lymphatic system through the lymph nodes and then out through the kidneys, which is not a fast process. That's why this treatment, once you develop the swelling, the treatment is lifelong. And you can develop the swelling at any point of the continuum. You could develop it the day after surgery. Truthfully, you could develop it 20 years after treatment because those lymph nodes are still damaged and their ability to transport the amount of fluid that the body produces on a daily basis is limited. So yeah, it's complicated, but no, it's not. There's no easy fix. I think I'm going to get into the treatment of lymphedema and how it's how we treat it and how that.
I'll just jump in really quick and say I tell patients the best way to treat lymphedema is prevent it from happening in the first place.
Yeah.
And I just saw a patient this week that I treated for sarcoma of his right, kind of just adjacent to his right knee. He had multiple surgeries there. So I think most of the edema is actually surgical because I didn't treat circumferential or anything, but he just does not want to wear a compression stocking and he's got edema. And I keep telling him, wear it for a year. If it goes away completely, then maybe take it off. So then he finally agreed. He worked for 4 weeks and then he stopped wearing it. I said, no, wear it for a year, wear it till next summer and then let's talk.
Wear it until it's been gone for a long time and then start experimenting with if it's going to come back or not. You know, the treatment that we do for lymphedema, there's short-term treatment, there's long-term treatment. When you have, you know, gross swelling, sort of uncontrolled swelling, we have a picture here of bandaging that we do layered compression bandaging with short stretch bandages to actually manipulate the fluid to get your body to be able to get the fluid into the lymph nodes to be more likely to actually process it out. We try to make your lymph nodes process the fluid also by using manual lymphatic drainage techniques, massage type techniques, and what's illustrated in the upper left-hand corner is a compression pump, but something that's using to manually manipulate the lymphatic system through the skin to try to help push that fluid up toward the lymph nodes so that your body can process it out. And then the garments, yeah, absolutely. Compression garments, usually custom fit compression garments that are measured to patient specifications, and a very inelastic, so unstretchy, very firm garment is what's needed to keep the pressure on the lymphatic system so that the fluid doesn't accumulate on a daily basis. And truthfully, when a person has lymphedema, not just surgical edema, not just post-radiation swelling, you know, normal amounts of mild swelling, we're talking about, you know, hard swelling that doesn't go anywhere. You need to have pretty adequate, we're talking in the range of 20 to 40 millimeters of mercury of compression, non-elastic on that area, which is demonstrated by the garment on the hand and the garment on the leg. Any more questions? Sorry, I kind of went into the description. I felt like I should tell you about the treatment.
Oh, thank you.
Sure. Yeah, thanks for the question.
Were you going to talk about lymph node transfer? That would be the only.
No, we didn't put that in the presentation, but
no, that's
certainly,
okay.
Yeah, we certainly.
I was just going to tell Matthew, I mean, there are some plastic surgeons that do lymph node transfers. They'll take healthy lymph nodes from other parts of the body. I have no idea how, I can't even, and lymphatics, I don't even know how they find it. And they'll like interpose it between the normal tissue and the area with all the lymphedema. And I think in some cases it can be quite dramatic as far as the treatment, although I don't know. Yeah, I see Maria. Maybe I'm just hearing what the plastic surgeons want to believe.
Yeah. There's no cure. What I would say is there's no cure for lymphedema, unfortunately, at this point. There's a lot of things you can do to try to help. But yeah, we have, they call themselves super microsurgeons, surgeons that do surgery on the lymphatic system because it's so delicate and so tiny that they have to use radioactive dyes injected into the system to be able to visualize the system. And then they're using teeny tiny needles to anastomose lymphatics into the venous system and then transplant lymph nodes into affected areas. It's pretty complicated, pretty cool surgery, definitely. And there can be dramatic improvements in some patients, but it's the lymph nodes that are transferred into the area have to grow new lymphatics, which huge scrotum like you saw there down to normal. That's unfortunately not where we're at yet. Maybe someday when they can transplant and grow lymphatics for people, that would be great. All right, I'm going to hand it back over to Tom to finish up here.
All right, I'm back.
I like the tag team.
Yeah, so do I. I'm going to take over, talk a little bit more about exercise and physical activity for oncology patients. So decades ago, recommendations for oncology patients were basically rest, recovery, and generally inactivity. Over time, just as the oncology specialty within physical therapy has progressed, our research has shown that exercise we were actually exactly wrong about that. More research is showing the benefits of exercise prior, during, after oncology treatment, and has shown how detrimental inactivity can be for these patients. So it seems very obvious now that would be the case, but at the time, apparently, it was not as obvious. So the first research study that I remember hearing about was this PAL trial, so physical activity and lymphedema. And this was a trial that studied the effect of resistance exercise on women who had had breast cancer and either had lymphedema or were at risk for developing lymphedema. So I'm just going to read this quote from the paper. So current clinical guidelines indicate that women with and at risk for lymphedema should protect the affected arm from overuse. In clinical practice, this often translates into risk-averse guidance to avoid using the arm. This could lead to disuse pattern that may increase the likelihood of injury from common activities of daily living. So this kind of was a breakthrough that led to a lot of further research in the same vein. We were telling these patients to just rest and recover for years. And this was the first one that I remember that was saying, maybe the opposite is true. So since then, there's been 53 reviews. There's probably more. There's been all sorts of review articles researching the benefits of exercise and physical therapy before, during, and after cancer treatment, looking at effects of quality of life, strength, physical function, all improving with exercise intervention and treatment. Effects on fatigue is greater when exercise or physical therapy is applied during treatment. Pre-hab, which we talked about earlier, can improve adherence and tolerance to chemotherapy treatment. It decreased functional decline, improved hospital stay, post-op complications, return to functional status. So for these patients, exercise is very beneficial. In general, I'd say it's beneficial across all cancer types and a lot of different cancer-related impairments. Moderate, vigorous exercise has been found to be the best kind of intensity versus low or no exercise. Low intensity exercise has been shown to be beneficial for patients who are extremely deconditioned, improving cancer-related fatigue and affecting depression, anxiety, physical function. So in general, there's been all sorts of new research on how beneficial exercise can be for these patients. And I think they're finding that even patients who have low blood counts as side effects from their cancer treatment, they're mostly within reason safe to do exercise, and most of the time it'll be beneficial. You still have to be cautious and use your best judgment, but in general, we can have almost all patients be doing some sort of exercise. And this research is fairly new, so we're still kind of trying to figure out the details of everything. So a lot of different research studies are using different types of exercise for different types of cancer or treatment populations. So we're learning a lot through all this, and we're trying to just filter through everything to make general guidelines. So the research on yoga and Tai Chi and Qigong have been shown to have a greater impact on psychosocial domains that we're researching. Therapeutic exercise, resistance training, aerobic training can help manage the treatment side effects, increase treatment tolerance, improve functional outcomes. We found that supervised exercise had better outcomes than unsupervised exercise. And in general, serious events have not been shown to be common. So I think we've been very cautious with this patient population for a long time. And the more research we're doing, the more we're finding that they can tolerate it, it's safe for them, and it's beneficial for them. It's always a good motivator to talk to patients about how exercise can affect their mortality, their recurrence, and improve their adverse effects. So there has been found to be reduced cancer-specific mortality, decreased recurrence, and overall mortality in people who are exercising at a high level. And it's tricky to kind of interpret some of these results, but in general, for breast, colorectal, prostate cancer, and some other cancers, there's been shown to be a reduced risk of mortality, reduced risk of recurrence. And exercise in general has a positive effect on treatment-related symptoms during chemotherapy for breast cancer. High intensity aerobic exercise has been found to decrease treatment-related effects. For cognition, aquatic exercise has been shown to be beneficial, and this is for patients with breast cancer. A lot of the research you'll see on cancer is done in breast cancer just because it's a very large population. And in cancer-related fatigue, as a symptom, exercise has been shown to have a positive effect and is actually the #1 treatment for patients that have cancer-related fatigue. So we're getting all of this new research. It's all kind of pointing in the direction that exercise is good, exercise is safe, people should be exercising. We still aren't super clear on the specifics.
Tom, there's a question from Elizabeth. I don't know, Elizabeth, do you want to ask it?
Sure.
Sure. So I'm just wondering what kind of responses you see from patients, if you see any resistance on their part or, kind of hesitancy to engage in physical therapy at some point during their treatment, and then kind of what the approach is if that happens.
Absolutely. I think at a lot of different stages of treatment and after specific oncology treatments, you'll have different kinds of resistance. A lot of times after surgery, people are very anxious regarding using their, like for example, for breast cancer patients, they're often very hesitant to use their arm after breast cancer surgery. And sometimes coming to physical therapy, part of what is helpful is just kind of giving them reassurance that they are not going to injure themselves, or kind of just guiding them along the path of when they can progress and how much intensity is okay for them. In general, I think there's still kind of a stigma that, I'm getting this oncology treatment and that means I just need to rest. And I think a lot of times, especially for people who have like low blood counts and stuff like that, due to their oncology treatment, they don't feel like they have a lot of energy, and there's a very good reason for that. So just letting them know that if they're really having a bad day, they don't need to push themselves, but in general, if they put the effort forward to kind of focus on exercise, they can help manage their symptoms and have better outcomes. It takes some persuading sometimes, but usually people are pretty open. If you tell them that they're going to feel better afterwards and that you'll help keep them safe with doing it, they're usually pretty open. Hopefully that answers the question.
Yeah, thank you.
Yeah, I'll just add that personal my own personal learning with physical therapy is when I first started, again, I treated a fair number of patients with head and neck cancer, and we would kind of tell patients, oh, you know, would you like to go see the speech therapist, which is related to, you know, maybe similar in a sense to physical therapy, but different training. But and the patients often would go, oh no, I'll do it if I need it. And then they'd get into treatment, and it was kind of too late to get them in to see them. And so we've really changed the way we talk. Same thing with when I refer somebody to physical therapy. I don't kind of offer it as an option. I say, this is part of your treatment. You know, we're gonna treat you with chemotherapy, radiation, and you're gonna go see the physical therapist, the dietitian, and the speech therapist. And I feel like sometimes I think if the physician presents it as part of the treatment and not kind of oh, we can add this on if you feel like doing it, it can impact how the patient perceives it also.
Yeah, I completely agree. And I think, you know, worst case scenario, you send somebody to the physical therapist and we educate them and take some baseline measurements, and they find out they don't really need to be followed very closely by physical therapy. But there's been so many cases where you see somebody and, you know, I had a initial evaluation today, and this person had completed their radiation treatment for breast cancer 2 years ago. They've lost 90% of the range of motion of their shoulder. And, you know, we're going to have a much harder time getting that range of motion back now than we could have 2 years ago if they had actually shown up to their appointment. So getting people in the door is always helpful, and it's easier to treat people early than try to kind of later on try to go back and make up for lost time. So so I'm going to jump back into this. So there's been a lot of research into exercise, especially for breast cancer patients. There's a lot of different things we need to be evaluating for this specific patient population. So they should be continuously monitored for lymphedema, cardiotoxicity that you can find with some chemotherapy, cognitive impairment, distress, depression, anxiety, fatigue, bone health, pain, peripheral neuropathy. This is all stuff that should kind of be assessing throughout different points in their continuum of care. Our research says that they should be getting counseling regarding obesity, physical activity, nutrition, smoking cessation. All of these studies combine, and you know, we still don't have a clear description of exactly what everybody should be doing, which, you know, everything is going to be patient specific. So really the only general recommendations we have for exercise is the same stuff, the ACSM guidelines for everybody, doing 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous aerobic activity per week, muscle strengthening at moderate intensity 2 or more days a week. For older adults, they can do a little less exercise and they might have to do more balance exercise. And then adults with chronic conditions, it's the same stuff. So the broad exercise recommendations for oncology patients are the same for everybody else. But in addition to that, they need more specific PT guided treatment and exercise and stuff like that. But all oncology patients should be getting encouraged to do physical activity just like any other patient would. Any questions on exercise? I think after this, we're just going to do a couple of case studies. All right, great. I'm going to turn it back over to Maria. Thank you very much for having me.
Thank you.
All right, back just for we did 2 case studies because I think, you know, putting a face and an actual person to some of these impairments and issues is helpful in learning. So the first case study, I think there are 2 examples of pretty common patients that we see in our clinic. We thankfully get a lot of referrals from our head and neck oncologists and our breast surgeons. So 1 case from each type. A case study would be a 62-year-old male diagnosed with squamous cell carcinoma of the oropharynx. His details include that he is a former smoker with a 15-pack year history. His staging at diagnosis is T3N1. primary site of the tumor is the base, the right base of the tongue, and HPV positive. Past medical history is significant for hypertension, lower back pain, and obesity. And the oncologic history in general was that in March, there was a CT of the neck that demonstrated a 5.6 centimeter mass originating at the base of the right tongue, extending to midline with enlarged lymph nodes, let's say on the right side as well. The patient received chemotherapy through July, and the tumor shrunk by 36%. From July to September, the patient completed 5 cycles of chemoradiotherapy as an inpatient in the hospital. And in December of that year, because there was still a palpable lymph node, the patient underwent a right neck dissection at levels 2, 3, and 4. So I just, if people were wanting to participate, would ask, what impairments do you think we might see in a patient like this? This would be an example of the patient, photo of the patient from the front, and let's act like that's a male on the right from the back. Anyone want to say some of the things that could be present from treatment?
It looks like lymphedema is present.
Yeah. Yep, submental lymphedema certainly, and even in the cheeks a little bit as well. The photo on the right is showing some shoulder dysfunction due to the dissection. So some common issues with these types of patients. Some of these would be issues that a physical therapist would treat, some other parts of the rehab team. So issues with swallowing, obviously tongue cancer, tongue resection, would be that the patient has dysphagia or difficulty with swallowing. Radiation treatment can cause esophageal strictures, requiring dilation of the esophagus to help with swallowing. Obviously, because of the difficulties with swallowing both orally and through the esophagus, the patient is going to have a lot of weight loss, possible G-tube placement for nutrition due to the difficulty or inability of swallowing. Also, things outside the purview of physical therapy would be down at the bottom, oral mucositis and radiation dermatitis, changes to the skin and mucosa as a result of treatment. But things that the physical therapist could treat in this case would be the head and neck lymphedema. In that picture, you saw the person pre-treatment and post-treatment, the reduction in swelling. But again, lymphedema is a chronic condition, so it's reduced, but it still needs to be maintained with daily compression and manual lymphatic drainage. Because of the neck dissection and possible damage to the accessory nerve, the patient in the photo on the right there is demonstrating significant weakness of the scapula, the upper trapezius, causing dysfunction of the entire shoulder girdle. That would need rehab if possible, if that nerve was to regrow, regenerate, and work again. But if not, compensating for that loss of shoulder functioning, as well as decreased neck range of motion, certainly from the surgery itself, removal of some muscles and soft tissue, as well as radiation, making those skin changes, changing the flexibility of the skin in that area. Anything else that I might have missed that you guys could think of on that list? Dr. Golden, certainly.
I was gonna say, can I play? I mean, maybe a brachial plexopathy from radiation.
Yeah, yeah, absolutely.
I mean, generally with one course of radiation, that would be unlikely, but it could cause arm weakness, pain.
Yeah, absolutely. I think we see a lot of accessory nerve damage.
Yeah, I was going to say, I had a surgeon tell me yesterday in the doctor's lounge at my hospital that neck dissections don't cause morbidity, and I didn't say anything. But I'm like, everybody you see is like, I can't lift my arm up anymore.
Yeah, look at that shoulder. I mean, you can't lift your arm over 90 degrees for the rest of your life when when your accessory nerve doesn't work anymore. I have a very dramatic patient of my own right now with severe deformity from oral cancer. So yeah, unfortunately.
I was thinking you might see less of this because there's a lot of research into dose de-escalation with HPV cancer. So instead of giving 70 gray, maybe giving 50 to 60 gray with smaller targets because it's so sensitive to treatment. So maybe seeing less lymphedema, less brachial plexopathy, that kind of stuff.
Yeah, and I think that's something we learned a lot from the breast cancer population, because the morbidity was such a huge issue for patients, and their main complaint is that they've really refined breast cancer treatment to minimize those, to stop people from getting lymphedema. I think that could be certainly applied into other cancers if the money is there for the research. You could make a.
Actually, the reason that the conversation came up with this head and neck surgeon who's not affiliated with the university, somebody out in the suburbs, was I said, oh, what do you think about sentinel node biopsy for oral cavity cancer? Which in breast cancer, they used to do these big axillary dissections, and they found they could just do a sentinel node biopsy. And even if they're positive, you don't have to do an axillary node dissection as long as you give radiation after. And that significantly reduced lymphedema rates. And that was when his comment was, well, maybe we can just do a sentinel node biopsy to prevent radiation, because that's where all the morbidity comes from. And I just kind of said, okay. Like, you get used to that as a radiation oncologist. We're kind of the punching bag for toxicity, but it's okay.
Unfortunately, yeah, right. But surgery has equal amounts of damage and morbidity as well as radiation, I think. And then you combine the two together, and someone is going to walk out of there, unfortunately, with some sort of long-term issue, unfortunately. And that's what we're here for as physical therapists. All right, don't want to run into Dr. J's time too much. The second case study.
I'll just let you know really quick. She actually is stuck in the operating room, so if you go over a couple minutes, it's okay. And I'll talk to the students after. We'll figure out what we're gonna do. Okay.
I do also have my own patient at 5, but I'll finish up.
Yeah, no, that's okay. I was just letting you know she unfortunately can't make it today. So.
The second case study would be a 42-year-old female with biopsy proven right DCIS, high grade, ER negative, PR negative, and HER2. My videos are over the top of that. I think it's positive. Yeah. Breast cancer. Past medical history of hypertension and obesity. Her treatment involved a right skin-sparing mastectomy with complete axillary dissection, taking 16 nodes, 2 of which were positive. Excuse me, followed by immediate breast reconstruction with a deep flap from the abdomen. It's a common procedure done here at the University of Chicago with Dr. Chang and Dr. Garza. Microsurgery as well. And then adjuvant chest wall and comprehensive nodal, axillary nodal radiation. So some impairments that we might see in this patient would include decreased shoulder range of motion and strength after surgery, right arm pain, as well as axillary cording from lymph node removal, right chest wall and breast edema initially after treatment, after surgery that resolved, and then impaired skin integrity during and after radiation. And then after 6 months after treatment, the patient then developed an onset of right upper extremity lymphedema. In that picture before there, it's a common example of scarring and cording that occur after axillary dissection. Just went to a conference with breast surgeons and lymphedema surgeons, and they dismissed cording as just venous congestion after axillary surgery, when it's probably one of the most common complaints persisting weeks after surgery that with patients, that the lymph nodes are removed from that area, but the lymphatics that drain into the area are just left behind, oftentimes filling and congealing with the lymphatic fluid and sort of turning into scar tissue that can be very uncomfortable and limiting to patients' recovery in range of motion. That's what the picture is on the right there. On the left would be, you can see the incision from the mastectomy, probably a lat flap incision in the chest wall, and all of that scarring that occurs with the axillary incisions. Frequently, scarring is a limiting factor with patients, and not a lot of treatment that can be done, but working on the range of motion and restoring some strength and motion to that area would be things that a physical therapist would work on. I think that's it, and just the references in the slides for you guys as well.
Hi, Daddy. Hi, Daddy.
All right, does anyone have any?
I apologize.
You pushed me back.
Anyone questions? All right, well, thank you guys for attending. Appreciate your interest.
Sorry, I had a certain roommate that interrupted. I would just ask you, I guess, if you had to tell future physicians, can I give them a message about physical therapy? What would it be?
Yeah, I thought I tried to throw that in with my presentation, but it would be, and you guys are all interested in possibly oncology, right? There's a oncology specific, yeah. Would be that idea of educating patients on the possibilities of long-term consequences of cancer treatment. That survivorship is a wonderful thing, that people are extending their lives, living much longer, but the long-term consequences are there. That they really can be helped with physical therapy, occupational therapy, speech therapy, with that early intervention. So if you could refer them to us, so that we could at least do education, so that if something changes in their survivorship, that they will know that we're resources for them to come, so that we can help restore them to as much of a return to function as possible, but also with that expectation that it might not be 100% after life-saving treatments. There are going to be some sequelae from that. I think that's what I spend a lot of time educating my patients on. So if you guys could do that, that'd be great too.
Okay. Awesome. Well, thank you. I noticed Matthew had asked earlier about something being a radiation side effect. I don't know if that was the lymphedema, Matthew, maybe, or so. Yeah, so radiation can damage the lymphatics. So it doesn't happen immediately, but months or years down the road, you can get swelling from damaged lymphatics. And in head and neck cancer, generally what we'll see is 6 to 12 months after, they'll get a lot of submental edema. If you need to go, by the way, Maria, that's totally fine.
Okay. All right.
Anyway, thank you so much. That was awesome.
Thank you guys. Take care.